Iron deficiency anemia. Iron deficiency anemia is the most common cause of microcytic anemia. Other than hemoglobin, iron is also a part of many enzymes in the body, which are vital for tissue respiration and organ function. Iron is the commonest deficiency disease all over the world. It is widely prevalent in India and is more common in pregnant women. Causes of iron deficiency. There are main three causes of iron deficiency. First one, decreased iron intake or absorption, which include inadequate diet, malabsorption such as celiac sprue, Crohn's disease, post-gastrectomy, acute or a chronic inflammation. Second one, increased demand for iron such as rapid growth in infancy or adolescence, pregnancy, erythropoietin therapy. Third one is increased iron loss, which is caused by acute blood loss due to blood donation, trauma, chronic blood loss due to peptic ulcer, GI malignancy, hookworm infestation, and menses. So these are the causes of iron deficiency. Coming to the clinical features. Clinical features include those due to anemia and those due to underlying disease causing iron deficiency. Coming to the symptoms, which include insidious onset of fatigue and exertional dyspnea, palpitation, tinnitus, and headache due to hyperdynamic circulation, dysphagia, which is more for solids than for liquids, due to formation of mucosal webs at pharyngoesophageal junction. It is called as Plummer-Vinson syndrome. Amenorrhea or menorrhagia, excess hair loss, and pica due to iron deficiency. Geophagia is common in children and pregnant women. Phagophagia, excessive eating of ice, may be seen especially in women. All forms of pica are relieved by iron therapy even before the anemia is corrected. Iron deficiency also causes functional impairment of various tissues such as myocardium, peripheral nerves, jejunum, cerebral cortex, kidneys, and liver. Coming to the signs, which are glossitis and angular stomatitis may be present. Papillary atrophy of tongue makes it appear smooth and pale, which is also called as a ball tongue. The next sign of iron deficiency anemia is flattening and concavity of nails are called platanichia and koilonychia respectively and are seen earlier in toenails than in fingernails. The next sign is mild hepatosplenomegaly may be present. The triad of dysphagia due to esophageal webs, koilonychia, and splenomegaly in a patient with iron deficiency anemia is known as Plummer-Vinson or Patterson-Kelly syndrome. Webs and dysphagia do not respond to iron therapy. Dysphagia is treated by passage of Bougie and dilation. These webs are premalignant. Coming to the investigations. Investigations are required to confirm the diagnosis of iron deficiency and to determine its cause. Complete blood picture such as RBC count, hemoglobin, hematocrit, MCV, MCH, and MCHC are all decreased in iron deficiency anemia. Peripheral blood smear, it shows microcytic hypochromic RBCs. There may be other morphological abnormalities such as poikilocytosis and presence of target cells. Reticulocyte count is normal unless the patient had a recent acute blood loss or has received hematinics. Serum iron is decreased, TIBC is increased, transferrin saturation is low, and serum ferritin is less than 10 microgram per liter. Bone marrow, it shows micronormoblasts. Iron stores are absent or markedly reduced. Investigations to identify the cause of iron deficiency: stool for occult blood and helminthiasis. Upper GI scopy to rule out peptic ulcer or malignancy, etc., depending on the clinical presentation. Coming to the treatment. Treatment involves replacement of iron and correction of cause of iron deficiency. Iron can be given orally or parenterally. Oral iron therapy. Oral iron therapy is safer and cheaper than parenteral and is preferred. Iron is best given as a single dose at bedtime. There are many iron salts available such as ferrous fumarate, ferrous sulfate, ferrous gluconate. There is no significant difference in the absorption of these salts. Oral iron is better tolerated if given after food, but may be absorbed less efficiently. Iron is better absorbed in the ferrous form than in ferric form. Iron absorption is increased by simultaneous administration of ascorbic acid and decreased by antacids. Certain antibiotics, for example quinolones, tetracycline, dietary fiber, tea, coffee, eggs or milk. Hemoglobin level will normalize in about 6 to 8 weeks of iron therapy. However, iron therapy has to be continued for a total of 6 months to ensure repletion of the body iron stores. Adverse effects of iron include nausea, vomiting, epigastric discomfort, constipation or diarrhea. They are dose related and can be reduced by gradually increasing the dose and giving it after meals. Coming to the parenteral iron therapy. Indications. It is indicated in patients who cannot tolerate oral iron and in pregnant women who present with severe anemia very late in pregnancy. Patients with the gastrointestinal diseases such as peptic ulcer and ulcerative colitis are likely to be aggravated by oral iron and need parenteral iron. Parenteral preparations. There are many parenteral iron preparations available. These are iron dextran, can be given either IM or IV, ferrous gluconate, complex, and iron sucrose only for IV use. Injection should be given after a test dose because there is a small risk of anaphylaxis. Intramuscular iron should be given by the Z-track technique to prevent staining of skin at the injection site. However, IM injection is not commonly used nowadays due to injection site pain and skin staining. Iron can be given as a single dose IV infusion. For giving total dose iron therapy, the dose of iron can be calculated by the formula in the square bracket 2.38 into W into D bracket complete plus 1000, where W is body weight in kg and D is the hemoglobin deficit in gram per deciliter, 15 patients hemoglobin. The value obtained is the required quantity of iron in milligram. The addition of 1000 milligram is provision for the body iron stores. Coming to the side effects of parenteral iron therapy. Both local and systemic side effects can occur following use of iron dextran. Local reactions